development chair. And I will have to say that Mike is the most academically creative person I have ever met. He is a fountain of ideas, and you have all benefited from them, from all the peer activities that he has created, like peer-to-peer and Pequod and coffee coaches and writing groups and poster-to-paper groups. He just is one wonderful idea after another. This jargon talk, I honestly don't have a clue what this is going to be about, but he gave it somewhere. I don't remember where first, and the people who heard it invited him to give it somewhere else, who invited him to give it somewhere else. It's clearly been a hit all across the country, and so now we have the honor of hearing it here. So, Mike?
Thank you. Please stay seated. So this is actually, we're going to start a little bit different. So again, I'm Mike. I think everybody in the room. What you may have seen me do before in talks is I'm going to actually give a shout out early on to two collaborators who have been part of this work, and I'll share some of their efforts along the way, but Jordan and Marissa as well. No conflicts of interest in the jargon world, luckily. That's a jargon term in and of itself, I guess, conflicts of interest. So who has seen me do the talk on magic? Has anybody seen me do that talk before? So fair amount of hands. So I'm going to start with a magic trick to illustrate something, but I need somebody to join me up here. Kathy, would you join me up here for a second? The reason we're going to do this, I'm going to have you have a seat. Everybody knows Kathy from the NICU. I'm going to have you start. I'm just going to place this kind of right here. I'll balance that. What's inside that box actually doesn't exist yet. Now, that'll make sense in a second, but what's inside the box doesn't exist. I'm going to start by having you take out a card. It's not the kind of trick where I can't see it, so you'll show it to all of us right away. So we'll say what it is. It's the Two of Hearts. I'm going to have you sign your name on that card. The reason I have her sign the card is it makes it the only card of its kind in the world, correct? Right? Unless you make a habit of signing cards, but I'm assuming she doesn't. Perfect. Kathy's Two of Hearts has her name on it. Now here's what's going to happen. I'm going to place your card halfway in the deck and snap, and one card becomes a little bit different than the rest. Do you notice one card's blue? Would you be mildly impressed if the blue card was your Two of Hearts? But I don't want to just mildly impress you. I want to really impress you. I'll try something else. Hold your hand flat for me, and I'll actually let Joe do this from the cheap seats. As I go through, say stop for me. That's the Six of Diamonds. Joe has the Six of Diamonds. You've got the Two of Hearts. If I shake, they change places. That's the Two of Hearts with a red back. Take a look in your hand. That's Joe's Six of Diamonds, but that would be impossible. So once I have hold your applause. Once I have a card selected, I can't get rid of it. If I take Kathy's Two of Hearts and put it in the deck, the next card, the Six of Diamonds, goes and brings you back to the top. And that was a little fast. I'll slow it down. The two goes in the deck. This one sends it up my right sleeve, down my left sleeve. That's two. Kathy, close your mouth. Even if you get 52 cards away, that's from the top of the deck to the bottom of the deck. It still climbs 51 steps back to the top. That's three. I'm going to do it so all the way in the back, you guys can see this. If I put a bend in Kathy's card, it now becomes very obvious when it goes in the deck. Can you see that in the back? Don't blink. 3, 2, 1. Right back to the top. Now, do you remember the box I told you about? I said what was in that box didn't exist. Could you cup your hands for me? I want you to I'm going to lift the top up. Can you tell everybody what you see in there?
There's a cut-up card.
A folded card. Go ahead and unfold it for us. The reason it didn't exist is Kathy hadn't signed it yet. Give her a round of applause. Have a seat. The reason thank you, Kathy. The reason I start with that is I'm going to tell you how to do that right now. I'm going to tell you word for word how to do that trick so you can do this tonight. So it starts as Darwin Ortiz's Red Hot Mama with an odd-backed face card duplicate at the face of the deck. That's used as a key card so that once the card is signed, the key card can be used by a series of doubles, which leads you into an ambitious card routine, a Mercury card fold, followed by a Doc Eason flip and a Hang Ping Chin. So everybody understand how that works? Now we can move on. That is how I did the trick. That is exactly, if there was a magician in the room, they'd go, oh my gosh, that's awesome. I understand how to do that. But I'm guessing nobody has an idea how I did that based on the description. That's what our patients feel every time we use jargon and talk to them. We confidently use terminology that means something to everybody else in the circle and is meaningless to the recipient and is just like you couldn't go home and do that magic trick right now. A patient couldn't go home and follow their medication regimen if we're doing that when we talk to them. That's the whole point of today's talk, is to start thinking about if we're going to recognize, one, that we use too much jargon, In order to be able to recognize that one thing, we've got to understand what jargon is and categorize it. So I'm going to share some work that Marissa and I did as we kind of put some labels on some of this jargon, and that's basically what we'll go through. Osler's, one of his famous quotes, is from the standpoint of medicine as the art for the prevention and cure of disease, the person who translates the hieroglyphics of science into the plain language of healing is certainly the most useful. This is true. What I would argue is we forget what plain language is. We just forget that we didn't know these terms at some point in our lives. And that's what I want to help us kind of wrap our mind around. We'll do that by kind of going through three broad categories this morning. The first is spending a little time. What is jargon? Why do we use it? And kind of why is it a problem? So I'll share some of the data there. We'll move into this classification system so that in order to be able to treat this jargon oblivion, we have to be able to diagnose it. And so we're going to start by labeling what types of jargon, go through 7 categories of jargon usage. And then finally, we'll spend some time moving from jargon and looking how just a single word change in the way we share information can change the entire meaning of the encounter. So we'll focus on about 4 or 5 simple swaps to add to your vocabulary that can change the way we communicate. So let's get started with the definition. Who's willing to throw something out? What's jargon? What does jargon mean to you? Joe? A specialized use of language. So often when we say specialized, it's a narrow group. Who feels jargon when you go get a car and they talk about your fan belt and it's just like, I guess that's important. I didn't know. I mean, I've been driving without my fan belt working. That feeling is again what our patients feel. So the dictionary definition is technical terminology of a special group, of either an activity or a cohort of people in that kind of activity. So why do we use it? Who's willing? I'd love to hear a couple just popcorn things. Why do we use jargon? Shout something out. Shortcut to communicate with each other. Those may be similar things. You know, it does sound a little weird if I call the surgeon and say, yeah, I've got a kid with a tummy problem. So yeah, certainly professionalism as colleagues, shortcut. Why else?
We all want to name things.
Yeah, we like to we are a species that wants to categorize things. It's nice to put a tight name around something. Any other ideas? So that's an important one, to establish power. And I don't think we are typically cynical when we use jargon, but I know when I don't understand something really well, sometimes jargon gets me out of it. It kind of hand waves my way past a really clear understanding of something. And I think that if we dig deep, maybe sometimes we are weaponizing jargon occasionally to kind of shut something down and leverage power. So, shortcut, absolutely. I think, one, we are taught jargon we've got 2 med students here, taught a language that I'm going to then tell them to forget. I think that we are just trained to use jargon. We're trained in our presentation to do that. There's a lot of work going on now, even at this institution, to untrain that. But I think as we're doing it, it's like, okay, I know how to say the buzzwords. I don't even really know what it means, but I can do the buzzwords early in my training. And then kind of to Peter's point, maybe it's to look smart, leverage power. I would argue the least cynical version is that we just forget. We don't even know the words we're using. We don't know that 80% of people don't know what the word febrile means. We just forget that there was a time we didn't know what that meant. And so I think that's where we'll spend some energy in the value of categorizing this. To Peter's point too, as we think of like us in a relationship arc or a relationship spectrum, of any encounter with a patient being from calm to crisis, and somebody is empowered and somebody is vulnerable. As our patients are here, they are in a crisis zone and especially vulnerable. We've done this before. We've done a code. We've shared a diagnosis of lymphoma before. So we're in this empowered and often projecting calm, and that leads to us to overestimate the ability for them to understand what's being said, and in that position of lack of power, patients are less likely to call us on it. So they're just going to do the bird that dips in water, kind of nod as we go along. So it creates a chasm that can be we can be oblivious to. Throughout the day, I'll go through some morning. You're not here all day, sorry. I will share some studies, but really the theme to all these studies is that we view ourselves as really good at this. Jargon is a problem, but it's not not my problem. I am a very effective communicator, but geez, I was in the room with a nephrologist the other day and I didn't understand. So we tend to lake woebegone this and think that it's somebody, we are in the top 50%, the top tier on this, and it's another person's problem. Who's ever like been to a sermon and thought like, oh geez, I wish my mother-in-law were here for this one. It never applies to us, right? It applies to somebody else. What I want us to realize is this applies to us. I am addicted to jargon. It is something that I struggle with. I catch myself on when I'm on teams with residents. I ask them to call me out on it, and it becomes our goal. We should realize we could all be taking this pledge right now. Okay, so that's the background. Now let's move into some of the work that Marissa and I kind of put labels on these. What do we mean are the types of jargon? I'll start with actually a clip from a scientific show.
Look, I'll take 10, you take 10. Get in, get out. No smiling, no hugging, no letting them cry. Just be quick about it.
You're the one that's slow.
I am not slow. You are slow.
You want to bet?
Yeah, you are.
A comprehensive workup
Did not reveal any
vascular abnormalities
Your Doppler was negative
for deep venous thrombosis, so there's no need for chronic
coagulation or an IBC
Your
filter
biopsy was, however, positive
for a mixed anaerobic
non-group-based streptococci infection.
Your BUN and creatinine elevations had us worried,
Rapidly progressive glomerulonephritis.
which could have signaled an autoimmune disease.
What does that mean?
We're not going to amputate your leg.
You get to keep your kidneys.
Congratulations. You can go home today.
Yeah, congratulations, whatever.
We're going to be fine. Congratulations.
I think it's actually telling that once they speak clearly, that's when they actually connect with the patient. And I will tell you, it's kind of, when you look at that, you're like, oh, I would never do that. That is rounds. I mean, that language, there's very little in there that is something that we do not hear at the bedside when we're sharing. So I think, again, rather than thinking this is somebody else's problem, I'm encouraging us all to be introspective in how we play a role in this. So our first of 7 categories is probably what everybody means when they say jargon. So I'll give a sentence. Your jaundice, which is due to elevated bilirubin, could be caused by cholecystitis. We're waiting for the radiologist to read the abdominal ultrasound to see if you may need a cholecystectomy. A couple of us might look at a few of these words, but I'm going to challenge that there's at least 10 in that sentence. We'll go through. So medical terminology, words you definitely learned in medical school. So these are disease names. A cholecystitis, organism, tests, ultrasounds, MRIs without context mean nothing to patients. Procedures, drug names, specialties. Who has struggled with forgetting that people don't even know what their job title means? What it means to be an endocrinologist when you go in a room's patient. There are lots of studies. There was one done by adults in a breast cancer waiting room. And only 1 in 4 knew what a radiologist was when asked in this waiting room. These are people that were doing it. And about half of the women knew what an oncologist was. And they were being treated at an oncologist clinic for breast cancer. So when we think about what does our job mean, what does a nephrologist mean? And we say, oh, it handles the renal system. That might not clarify things. So category 1 will spend the least amount of time because it's the terms that should be, if you do some reflection, the most obvious. The kind of corollary to that is things like this. Your EKG was concerning for an MI, but before you go to the cath lab, we'd like to get a CBC and coags and make you NPO. So this category is acronyms or short, abbreviations. The challenge with many acronyms is even if the person tries to go backwards and figure it out, it doesn't work. Like no patient, when we say NPO, goes, I wonder if they mean Latin, not a part of aura. I don't think, or nil part aura. I don't think they go that way. Or we say things like, or we will clarify it. We'll say an MI, myocardial infarction. And we think that we've just clarified the jargon, but we've just replaced it with another jargon term. Other times, again, NPO doesn't work. It's also a weird way. So what you'll hear people say is, they'll say, okay, don't say NPO. I'm going to say nothing by mouth. That is also a weird way to tell somebody to not eat or drink, to not take their medicine. That's a jargon. I mean, who says like, I'm starving. What should I do by mouth right now? That's not the language that we use, but we think we're clarifying it by not saying NPO, but we're still creating some confusion. And so really thinking what I have understood if anybody has a non-medical spouse or partner, this is a really nice practice is, hey, would you know what this means? And it's amazing how often The answer is no. Again, there are acronyms that mean different things. Joe mentioned to me that his whole career, TBI, was total body irradiation, and now it's traumatic brain injury as well, but that can lead to confusions when you're looking at a note. You could lead to complete medical mismanagement if you were, an ASD for me was always atrial septal defect, and I kept seeing notes when it meant autism spectrum disorder and was confused to why there was so much emphasis being placed on this septal defect. So again, simply stating out the acronym doesn't do the jargon, and this can be a really easy place to just catch ourselves. I can find myself, I can take one step in the right direction by starting to try not to use acronyms or abbreviations with patients without explaining it, just by expanding it out. This is where it starts to get a little tricky. So those ones are like, okay, I could try not to do this. These are the terms, medical vernacular are terms that are familiar. So people have heard them before. I call it medical TV show jargon. They've heard things like stat and, wide open fluids, but they don't know what it means. If they're actually, in the studies that ask people to define things, almost all the terms I'll talk about are about 50% understood or less by patients. So febrile, afebrile, sepsis, cultures. We're going to do a differential diagnosis. I remember doing a sim, my first day as an intern. They randomized us into groups to go into a sim center alone and do a code. And it was a pulseless electrical activity, which I didn't even know what that was at that point in training. So I kind of looked at the monitor and saw a heartbeat, so didn't think I needed to do anything with the heart. So I'm trying to intubate, and I had kind of no idea what I was doing. And I remember I just said, run the fluids wide open as like a television show thing. I was like the only thing I knew to say at that moment. But I didn't even know what that meant in the medical context. Remission, there was a study that looked at, again, of cancer patients, and more than half didn't know what that word meant, even if they were in remission. So we can just think that things like malignant, when we use euphemisms for certain things, we'll talk about that as well. So these are these familiar, they've heard them before, but they don't know it in a medical context. A very easy one to remove from our arsenal are synonyms that have a very uniformly understood word that we medicalize. So instead of an arm, we say their right arm, we say their right upper extremity, because somebody taught us to do that in medical school, and patients don't know what we're talking about. And I spend so much time doing the jargon, I'm more likely to make a side error by thinking of upper extremities and lower extremities than their right hand. Who has struggled? I have to remind myself all the time when I'm looking at an optho note, why can't they just tell me it's the left eye? We could both agree on that, as opposed to, OS or OD. Why can't they say both eyes instead of OU? I think there's a lot of examination we could do as a career. I've had many people say, like, we would like to get you up and ambulating today, and seeing patients just kind of blankly stare and then say, well, can I walk today? Maybe we could have spared that. Again, just like we don't say nothing by mouth, we say to people, how's your oral intake? That's just a weird way to say, were you able to drink or eat today? And really catching ourselves. Or if we're providing a synonym for something that a kindergartner understands the other word, we're showing off accidentally and confusing patients. There's a nice study looking in the waiting room of a orthopedics clinic, and they asked if your doctor told you it's a fracture or a break, what does that mean? Kind of going through. And 3/4 or 81% thought there was a difference, with 3/4 thinking a fracture was better than a break. Who's had this sentence happen? Oh, it's just a fracture. Thank God I thought it was broken. And that is a reality. They're the same thing if you're Googling it right now. But again, this is that can be a source of confusion, where we provide a medical synonym for something that is uniformly understood. Twain famously said, I never write metropolis for 7 cents because I get the same price for city. Simplicity is the goal in understanding, and there's plenty of data to support that. Okay, our fifth category. So I don't appreciate any focal tenderness in your abdomen, and the CT scan was negative. This category is one of my favorites. These are words that we have applied medicalized English. We have taken a word from English, assigned a medical definition to it that's different than what everybody understands the word to be in society. So appreciate, if one of my residents says to me today, I don't appreciate a murmur, what they're saying medically is, I don't hear one, but maybe you will. It's a little bit of a cop-out, right? Like, I don't appreciate a spleen tip, but would you check? That's not the way the word is used in English. My wife was looking at family vacation pictures of her own family, and she said, gosh, my mom's gained weight. And I said, really, I don't appreciate that. And meaning, I don't look at the picture and see that she's gained weight. But she goes, what do you mean you don't appreciate it? And I go, I just don't appreciate that she's gained weight. She's like, I don't get why you matter. They were in Barbados. You know, and I was like, oh my gosh, we use that word differently. Impressive. Medically, we tend to mean like it is of concern. I had a patient once that the dad said, would you look at this diaper rash? And I opened it up. I said, you know, it's not that impressive. And he goes, his penis? And I went, thank you for clarifying that. Had you just assumed that's what I meant and yelped, I'd be in trouble. So yeah, I was like, no, my gosh, and kind of realized like, oh, that's another word that we use. And these ones are challenging. And this is where, again, realizing focal means something different. Discharge is not, who said this? I think you can be discharged today. What questions do you have? When can I go? Can I go home today? It's not a word. We don't say I'm going to be discharged from the military, but we don't say I'm discharging from the hotel today. I get to go home. We think you can go home today. Admitted precautions. When we had our son's tonsils out here, my wife said, can Jack swim? And they said, yep, there are no precautions. And instead of saying, yes, he can swim, she goes, okay, well, can he swim? And she goes, well, yeah, of course, there are no precautions. And she goes, okay, but can he swim? It literally happened 3 times. I was like, again, a word that isn't really how it's used. We've medicalized it in a way, and then we forget that we weren't the ones that invented that word, and we kind of take ownership of it. How can they not understand? I'm saying precautions in that context. So take one tip there. Take cues from your patients. That stare and the actor does when he's doing that means you're not making sense. And we'll talk about some ways to get teach back in there too. This is my favorite study. This is 1,000 people in a vacation town in England. And they went up to 1,000 people at a beach, and they just gave a list of questions and said, if your doctor said this to you, is it good news or bad news? And the sentence was, the tumor is progressing. Half the people thought that was good news because progress is good. I would never have thought that could fall into jargon. And this just shows that that is pretty strange that things are progressing nicely at work. Our house is being built and things are progressing nicely. The tumor's progressing. Doesn't that sound, if you speak English, doesn't that sound like good news? And so it can be really challenging. There's a lot of work in the space of positive and negative. In the real world, positive is good. Be positive. I got positive feedback today. That restaurant had positive reviews. Negative means bad. I got negative feedback. Don't be so negative. I was told I had a negative personality. All of a sudden, the only place this is not true is medicine, where we say positive is bad. Your lymph nodes are positive. The MRI was positive. Negative is good. The test results were negative, unless it's maybe a pregnancy test. So there can certainly be times that even that can be confusing when we say something negative can be bad news or good news, but just not used that way in society. I will share some examples of some ways to swap out some phrasing in a few slides that can help us there. So I mentioned this a little bit. The 6th category is euphemism jargon. So these are words that we try to soften a phrase by substituting another phrase. And I know I've done this with death. We have a very hard time as providers saying die or death if somebody died. And there's a ton of literature that shows that if you don't say that, people don't know their family member died. And so you can say, passed on, we tried everything, we weren't able to be successful, and we'll get somebody else to try. They hear the we, they don't take to the next step of the euphemism. And so there's a lot of data in the Breaking Bad news world about the need to say they died. If the patient died, don't say it otherwise. Another example of euphemisms is a study that looked at who does this with, we try to simplify things on imaging. So, there's some schmutz on the x-ray, or there's a spot on the x-ray. This followed people months out and showed that hearing a spot on the x-ray versus those that had actually been kind of told what that meant, just left with spot, carried anxiety for months. And so what we were trying to do was soften the anxiety by using a euphemism, and we were ultimately creating more. We're pediatricians. We can say pee and poop. It's a little confusing to ask a kid if they voided, or parents if they voided. My sister was in the hospital when she was a teenager, and the nurse said, has she moved her kidneys? And I said, like, instead, like, moved your bowels? And I was like, I don't know. Like, Lindsay, did you move, what does that even mean? So really, if you're softening something, you might be creating a little more confusion. And I know, I mentioned we have a hard time saying cancer, and so we say malignancy or lesion, or we say something that might just create more confusion. And the last category before we involved two of our students to share a little bit of the work that's happened here in Masonic and then wrap up with some of the swaps is this category called judgmental jargon or loaded lingo. These are terms that we probably are not using maliciously. We almost always are not. But a patient, because of all those things we've talked about with words meaning things in different language, can hear it and kind of bristle at the way that lands. So non-compliant, we say somebody's non-compliant with their medicine and we're presenting in front of them and they're like, I just can't afford it. I'm not compliant or my other doctor told me to say it. So this can land. There's a lot in the literature around the language of deny. When especially in the open notes era where patients can read notes, the most commonly cited frustration is that when we say they deny alcohol use and they're like, I just don't drink. Why would you say I deny? I'm not denying it. You didn't accuse me of it. You asked me. And we don't say somebody denies limp. We just say they're not limping. And that can land. Even though we know we're not being judgmental, when that's landing on the ears of patients, there's work that shows that it is. And patients leaving their providers when they see in the notes things like denies sexual activity, denies alcohol use. Patient complains of who was taught a chief complaint? That's kind of obnoxious, right? So patients complaining of, oh, no, I'm not. I'm in the hospital. You told me to be here. Just even as we're presenting and our med students or our residents are presenting in front of the patient and we start talking about the complaint, that is language that can land differently and there's data to support that. Failure of treatment, can be perceived as a failure of the patient. My son had failure to thrive in the first months, and that failure stung, even though I knew the word. I knew what we were talking about. And so just thinking of the way that can land. And then there's in this euphemism jargon, in this judgmental jargon, are words that really, if we paused and said, gosh, should we be saying Gomer? Should we be saying rock? Or FOS on an x-ray that's kind of playful. But then if a patient said, what is that? Well, it means he's full of, it can be a little hard to justify. And so these are just ones that if you just pause and reflect, it's probably time to think about removing some of these words from our vocabulary, not just avoiding them as jargon. I want to take a second to make sure I'm clear that this is not a session to say never use medical words. This can go too far. We had a patient with meningitis and it was in the discharge instructions. And they're like, whoa, I just thought I had an infection. The parents, I didn't know this was meningitis. And that was a failure of an overcorrection. All the literature on jargon, including what Corinne and Rachel will share in a second, jargon means undefined. So just saying meningitis and not clarifying what it means. It's important to empower people with the language of the terminology of their affliction. It's not, so don't swing the pendulum so far. So with that, we're going to take about 5 minutes to hand it off to two med students that worked on a project with Jordan and I, looking at applying this classification system to our hospital setting. And we'll save questions for them at the end as we come back for kind of some word swap. So I'm going to introduce Rachel Gottlieb and Corinne Praska, who are going to take us through the next step.
Good morning, and thank you, Dr. Pitt. My name is Rachel Gottlieb.
And I'm Corinne Praska.
And we're two of the 3 medical students who worked on this project. As Dr. Pitt just described to you, jargon use is a common problem in the clinical setting. A lot of studies have been done looking at the outpatient setting and evaluating simulated scenarios, but there's very little data that looks at jargon usage in the inpatient setting. So our project sought to understand the frequency and types of jargon used in the inpatient during pediatric rounds in the inpatient setting by bringing the jargon classification system just described that was developed by Drs. Pitt and Hendrickson to the bedside.
So under the guidance of Drs. Marmette and Pitt, we received IRB exemption for 3 of us medical students to audit jargon use during rounds. So once per week for 12 weeks, one of us medical students attended inpatient rounds with the purple team. We went into each patient room and then kind of stood in the corner and observed patient interactions with the care team. And during those interactions, we recorded all jargon use and then subsequently noted if the word was defined or not. After rounds, we met with the team to describe the categories of jargon that were used during that day and then give some examples of words that were used. After 12 consecutive weeks of this data collection, we analyzed the data and classified each jargon word into one of the 7 categories that Dr. Pitt just described. Some words or phrases could actually fit into more than one category, but for the purposes of this study, we decided to limit each word to the single category that best described it. So, for example, abbreviating a medication, like saying Clinda for clindamycin, could technically be an abbreviation and medical terminology, but we just classified it as one that best described it.
So over the course of 12 weeks, we observed a total of 70 patient interactions. During these encounters, we recorded 440 jargon words, of which 309, or 70%, were undefined. This translates to about 6 jargon words per patient encounter. Words from each of the 7 categories described by Dr. Pitt were used. The most common category of jargon included medical terminology, or words that you were taught in medical school. That was about 38% of the words used. And some examples from this category that we recorded were gastroenteritis, Ativan, and endocrinologist. Medical vernacular, or words that are familiar but are not widely understood, made up 28% of the words used. And examples from this category included saturations, sleep study, and aspiration. And finally, the third most common category was abbreviations and acronyms, making up about 17% of the words used, and that included words such as NPO, TKO, and EEG.
There were some limitations to our study, including an inability to take into account patients and families with pre-existing medical knowledge. And then there was also the Hawthorne Effect while we were there making our observations. So the Hawthorne Effect is when someone changes their behavior because they're aware that they're being observed. Future studies could be expanded to take into account jargon use for other specialties or groups. And then we could possibly include patient and family reflections on the encounters or how much they're able to pick out the jargon usage as well. Our hope, however, is that by bringing attention to the words that we're using at the bedside, that eventually we won't need jargon people with scorecards like us to keep everyone on track. So we encourage you to take a moment to reflect on what your jargon scorecard might look like on a normal day.
And with that, we're going to hand it back to Dr. Pitt and come back at the end for questions.
So I was actually pleasantly surprised at 6 per encounter, which is a depressing thing, really. But some of the outpatient literature, some of the transcript studies are as often as 70 per encounter of unexplained jargon terms. So I think this was promising, and I think really the crew should be commended for the work of actually not just making this a study for study's sake, but actually providing an intervention as well of giving real-time feedback at the end of a day of kind of the types of jargon. And I know that works for me. When somebody calls me on it, I try to strike it from my vocabulary. Yesterday, I heard another one. He's stable in room air to the family. What does that mean to anybody? He's not needing extra oxygen. Or I'm happy with the way he looks breathing. So thank you for that. So this slide to me is the most important slide. Not because it's an old phone and it brings back memories, but because the whole purpose of rounds, the whole purpose of everything that we do with patients is for them to understand it. If we are the smartest doctor in the world that makes brilliant diagnostic decisions and they don't understand what we're saying, we are useless. We are as meaningless as the jargon that we are sharing. What I like to visualize every patient encounter is that when I walk out of the room, they are going to pick up their phone and call somebody and say, okay, the doctor was just in, here's what they said. If you apply that standard to can they make sense on that phone call, my job is to have them make sense on that phone call. That is the way you will start catching your jargon usage here. And I have started using the teach back method of saying, hey, I noticed mom's not here today. I know she's going to want an update. It'll help me understand if I've been clear in explaining all this to hear how you'll give that update. Would you mind if we just role played out that phone call right now? That way I can fill in any gaps where I'm not clear. Now, if you heard me 3 times, I made it my fault if they were wrong. if they got it wrong. So teach back that says, okay, we just told the parent, what did I just tell you? Like it's this very threatening, unsafe, I got to prove to my doctor I understood. This is, I'm confusing. I know I can be confusing. Let me hear it so I can undo my confusion, is basically what we're saying. And I will tell you dozens of times, patients say things that I go, I did not mean it to land that way. And I have a surgeon friend I was telling this to. She said, I just decided to try it with my next patient. I had told him the surgery did not work. We were not able to repair the nerve in his face. And I said, so I just want to make sure this is landing because I know I can be confusing, it can be stressful. I'd love to hear how you'll explain this to people when they ask, so I can fill in any gaps. And he said, sounds like the surgery went really well. You expect everything. It was just the exact opposite of what she thought she had said. I had a patient with a ruptured appendicitis that had kidney failure, and from contrast and sepsis. And I said, you're heading back up north today. We are sending you home. People are going to be asking kind of what the hospital was. Let me hear your summary of what this story was from the hospital so I can fill in anything we haven't been clear about. The mom said, well, his appendix burst. He got, his kidneys got in trouble and injured because of being so sick, but he got a picture of his kidneys and they're fine now, so we're going home. And they're normal. The renal ultrasound was normal. His creatinine was still 3. And that showed me that mom heard the good news, the renal ultrasound is normal, as good, I can stop worrying about the kidneys. And again, had that question not been asked, they were not understanding that when they left. And it's our fault. You can also do this for those of us that take care of people that have been transferred in. I know you talked to the emergency department last night, and the team that admitted you. Let me hear your understanding of what they told you. Not, why are you in the hospital? Because they say, well, I had 3 days of cough, and they go through the story. But what was told you to why you needed to be admitted to the hospital, why you needed to stay in the hospital overnight? Equip patients for the phone call. The other thing is we talked a little bit, we learned another language. The patients know 1, we know 2. We know medical English, and our patients know just their primary language. Eliminate the middleman. So when we're doing family-centered rounds, don't make it family-present rounds where they're eavesdropping on a conversation going like this, and then we just turn and say, oh, don't worry, I'll explain this in a little bit, or we keep parenthetically explaining a ton of jargon. Turn it into actual family-centered rounds where we are the attendings, are eavesdropping on a conversation with our learners and the family. So instead of Jack was afebrile overnight and his rash is no longer erythematous, tender, or desquamating, they just turn to Jack or this parent's like, I'm glad your fever's gone away. It looks like your rash looks so much better. I'm happy to see that. And I, speaking 2 language, can translate that into medicine if if I need to scratch that itch, or pruritus, I should say. So I hinted at this with a conversation with Joe earlier. We think, Sue said, this shortcut among colleagues, and absolutely, like I said, we're not going to say tummy, need a tummy consult. There's a place for this. We should just acknowledge, though, that we need to feel safe to say, I don't know what that is, when a person says a diagnosis or we see something in a note. And we are learners, too, and if a patient is on that wall, it's a lot harder for me to check my ego and say, I don't know what iris is when it's in a note from the rheumatologist, or I don't know what that means, and kind of putting some effort there. So again, if our patients are afraid to do it, we should acknowledge that we are too. So as we think of some of these swaps, I've mentioned this one before in some work we've done, there is a way statistically to bend time, to add time to the patient encounter without changing what's on the clock. So I can make it that I have more time in the room by doing one simple thing. Who knows what I'm getting at? Sitting down. So the studies out of Kansas, they followed surgeons into the post-op checks, and they watched whether or not the surgeon was standing or sitting in the post-op check. They didn't prescribe it, they just watched it. They timed how long she was in the room, and they asked the family how long it felt she was in the room. When they then checked those numbers, those that sat the families felt they were in there 40% longer. So you got this perceived bent time because you sat down. The part that's compelling of the study, they were in the room 20% less, statistically. So they actually spent less time in the room, gained a 60% kind of perception of time simply by sitting down. They've repeated some studies in a hospital setting of a leaning posture that just shows I'm not running out of here. You're not wasting my time. And so that can be a powerful swap to our style that can kind of set up a learning environment. Angie Smith and some others and I have taught the communication course through Abe Jacob and Andrew Olson through the university. And one of the analogies that has always stuck with me is when we think of the spiels of knowledge we have. I was very proud as I eliminated jargon from my vocabulary and continue to try to, I thought, I'm really good at explaining things. I have this 2-gallon jug of knowledge of bronchiolitis that I can explain without jargon. But if I look at the data on retention of 10 to 20% of what the patients retain from providers, they have a shot glass. And no matter how slowly I pour my 2 gallons of knowledge that I spent $186,000 to acquire, it's going to overflow and they're going to lead to the shot glass. So rather than, I had a resident once, because I'm in posture of feedback, say to me something that really stuck. I'm worried that you left the room and they think, wow, he's really smart. He knows a lot about X, but they don't understand what that is. That was very convicting of that I had this big gallon of a spiel and I've just started saying the job of us is to assess the shot glass and say, what are the 2 ounces that they need here? Maybe I can ask them. Maybe they're going to tell me they have more than 1 shot glass that we can fill up over time. But rather than saying, I had this long spiel about bronchiolitis, this long spiel about explaining why bilirubin was elevated in physiologic jaundice, and what patients want to know is, sometimes babies make this a little more than we do, and if it gets too high, it can be a problem, so we have a way to treat it. And that's what most people want. They don't want the liver and use enzyme names as you do it. Even though I was so proud of the fact I could make it a long analogy, I've dramatically cut my spiels down. Assess the shot glass. Check yourself if you're in monologue versus dialogue. Patients are much more likely to remember a conversation than a speech. So find a way to deal them into the conversation. I now have this like the devil and angel on the shoulder. I feel like a tap, like you're talking too much. I mean, my whole life, but in patient rooms, I feel this tap of 7 sentences in a row, 8 sentences in a row, 9 sentences in a row. Find a way to deal in. And an easy way to do that is if you share a diagnosis, rather than saying diagnosis is, start with what's your understanding of asthma? Or what's your understanding of bronchiolitis? And it very changes the whole dynamic of the structure. I'm thinking this is something that's called asthma. Some people have experience with it. What does that mean to you? Oh my gosh, we got 3 kids with asthma. But if I just did my whole spiel and they're doing this and they're like, yeah, no, I'm a PhD in asthma research, it doesn't give them a chance to deal themselves into the conversation. Deal them in by, instead of what the X diagnosis is, what's your understanding of this is a simple swap to kind of force yourself into dialogue. As you're doing that, as you feel the 7-sentence tap on your shoulder, that's when you can say, I'm talking a lot here. I want to check in. How's this landing? What does this mean to you? What can I clarify? Those are really powerful tools. One that's just been the last couple of years that I've worked on, trying to eliminate the word but from my vocabulary. When we say but, we tend to do it to negate the first clause of a sentence. I think you're doing a really great job on this rotation, but one thing I would do differently, well, they've immediately taken the compliment away and they're just crushed as they're waiting to hear what the difference is. Watch the difference of, I think you're doing a great job on this rotation. One thing I think that could be tweaked for the next tomorrow, or it could be done differently, putting a period where you would have said but changes it. Patient says, I just need to go home. I just want to go home today. Can I please go home today? And you say, I know you want to go home today, but we need to keep you in the hospital for antibiotics. Just kind of validates and then immediately unvalidates, as opposed to, I know you want to go home today. The reason we need to stay in the hospital 2 more days is. So just when you go to use the word but, put a period there. And it can be a really powerful tool. Replace word, or you can say, I know you want to go home today. And, I prefer the period, but some people do this really nicely with and as they swap that out. Nice literature around the differences between any and what. So if I say to a patient, do you have any questions versus what questions do you have? What's different there? I expect them to do it. There's a yes-no question versus an open-ended question. When they studied this with providers, 45% of providers shake their head no when they ask, do you have any questions? And we weaponize it. We try to use it to get out of the room as a wrap-up. We know we're supposed to ask and we ask. And saying, what questions do you have, does not open Pandora's box. What's the meaning of life? Most of the time the answer is, no, I think you addressed everything, or at least a pause and then a chance to ask a question. So expecting the questions. What questions do you have? What else do you want to make sure? Do you have anything else you want to talk about? Very, very, very different and kind of evidence-based. I will tell you, some of these skills, it's easiest to start them with an interpreter. So what I mean by that is we think we are in dialogue when we're with an interpreter. We're not. We're pausing a lot because we're waiting to hear ourselves talk in another language. It's a fake dialogue. If you start with an interpreter with some of these things, what's your understanding of bronchiolitis? It is the visual in the room is the interpreter is like, I'm not used to being asked to ask that question. And I certainly know I give substandard care when I'm using an interpreter, and this is a way to check myself on that by bringing some of these skills. What's your understanding? Forcing myself into dialogue. What do you want to talk about? What questions do you have? And really working with your interpreters to make sure that's being interpreted correctly. So is there anything else to what else? Do you have any questions to what questions do you have? I think a really powerful thing that can be added to our arsenals today is to share our emotion when we share a diagnosis. Who has done this before? You're sharing, or if you've ever been waiting for a diagnosis for a family member, you're watching the surgeon walk from the waiting room, like, oh, they're not making eye contact. Oh, they're okay. They're okay. You're just taking that whole thing, trying to say, like, what's this going to be? And those, the thumbs up from a distance, get that 5-second walk is pretty painful if you've been the family member waiting for it. Sitting down and saying, I got the blood work. I was really happy to see that. Putting an emotion makes that phone call make so much more sense. That makes them say, oh, the doctors were in and they were really happy with my x-ray today. Not, your x-ray was reassuring and progressing as I expected. Like, I was really happy with the way the x-ray looked today. Things are moving in the right direction. That makes the phone call make more sense. Using emotion words in the difficult emotions. I'm worried. And, when I saw this blood work today, I was worried. That is much more valuable than your platelets were 27. I was worried about your platelets. They were lower than I expected. It is really helpful for people. One thing I've started in the last year or so is trying to put the patient's name into the sharing of a lab information. So instead of the blood cultures were negative, so the subject and object, or there's just the blood cultures here. The blood cultures showed me that Sarah. If I change my language so I'm forced to use their name, that again empowers the phone call and makes it about them. So the blood work showed me that Sarah does not have an infection, which I was happy to see. That is very difficult to be confused by, versus the blood cultures were negative. And we've talked about negative and positive. What's a blood culture? And was it, exactly kind of this point. My wife pointed out that this is basically a Mad Lib that you can do with almost every test. The CAT scan showed me that Joe does not have a stroke, which I was thrilled to see. So if you put this rhythm into starting with the test, but forcing yourself to use their name, you will never say the CAT scan showed me that Joe was negative. You can't. The sentence structure doesn't work that way. And I want to just spend our last couple minutes shifting and kind of recapping something from a previous grand rounds we did around communication. And I've hinted a little bit around euphemisms and breaking bad news. And I think I used to think that as we learn bad news, that I got to be the one to decide it was bad news, that it was just, okay, this is a bad news moment, I need to go share something. What we know a lot, and what I've learned after some conversations with families of children with Down syndrome, is that is not my judgment call. That is an objective, I'm presenting something as objectively bad that the data will show me families don't come to see as bad. 94% of families with Down syndrome say they wouldn't change the chromosome in if they could, ultimately as they come to the diagnosis. I've had many patients say, we grieved what we thought, but we absolutely love what we've got. When I bring a diagnosis, I'm sorry you have bad news, that is projecting my bias as a provider. We talk a lot about implicit bias with race, gender, socioeconomic status. We have bias against disease. Those of us that did not, that did hem-onc as residents or just did stem cell, we just think that's the worst possible thing that could happen to you because you don't see the clinic side of it. You only think this is the worst possible thing because we're seeing the sickest in the hospital. That's true with patients with Down syndrome, for example, that we are going to have a biased view because of seeing only the hospital setting, not what actually this looks like for families in the community, and kind of checking our bias when we go to, is this objective bad news or am I projecting? And I learned something yesterday. I had been saying, as I shared new diagnosis of diabetes with families, I had really been wanting to say, okay, well, in my mind, that fit in the objective bad news, and I kind of got called on that yesterday, and I'm reflecting that for many, in fact, the resident that was in the room with his pump on was one to kind of say, like, this isn't bad news. And so this is an evolution for me. It is unexpected. It is a challenge. There are going to be lots of positives for what this can mean. And it's not my job to share something as bad news when it's not truly objective, death, car accident, etc. The first conversation I had with the family about this, the next patient I took care of had Down syndrome. And I asked the family, well, tell me about how you were told. And she said, well, gosh, don't go there. And she goes, but then I ended up looking up on the computer, and I looked up all these causes, these things that would be terrible with Down syndrome, all these side effects. And I wish now I could hack into WebMD and put at the top of the list, like, will be the joy of your family, will make it so that your siblings aren't bullies, will bring light into the rooms and the people that they interact with. Those are side effects that aren't talked about. And I wish that I could kind of hack into that list. And that's been pretty consistent and led me to join the board of the organization Jack's Basket, where we have kind of put together ways to think about how to share this diagnosis and celebrate and not think of it as bad news. Our paper in Pediatrics that we wrote with the mom I had coffee with as the first author. When bad news isn't necessarily bad, recognizing provider bias when sharing unexpected news. And it's a simple swap that applies to things like Down syndrome, but maybe I'm bringing my projected bias to hearing loss, to limb deficiencies, to et cetera. Really pausing and realizing it's not my job to project to start their story as if this is bad news. So I've really tried to be intentional except when I'm of course dealing with like an objective situation, which I'm learning is an evolving term for me. I'm sorry I have some bad news, to I'm sorry I have some news which may be unexpected. A swap that means a lot to families and really has been starting to make some changes in this community. So I'm going to end with a video. It's 1 minute. I will warn you that there's some bad language in this if you're offended by that. You may wish to leave. The part of the bad language really is a bias buster, and so I'm going to just let some of these kids speak for themselves.
You can say almost anything.
Like, holy shit.
You just had a baby.
Shit, yeah.
Congratulations.
恭喜恭喜.
She's so cute.
Oh, sorry, guys.
Yeah.
Congratulations.
恭喜恭喜.
She's so cute, I want to barf.
Well, there goes your sex life.
You just squeezed out a human.
Does your vagina hurt?
I hope you are ready for lots of shitty diapers.
Yay!
Behold, the miracle of barking life.
See, you can say almost anything.
The truth is, the only bad word is sorry.
Sorry.
You're supposed to be celebrating.
Woohoo! So don't be sorry about a baby.
Be happy.
Because every baby deserves a warm fucking welcome.
So that's
Congratulations.
恭喜恭
We're going to hear
喜.
that 3 times today. So again, I just the example of what one word can mean to family. So as we think about jargon, I want us to add some of these swaps to our vocabulary. For those of us that are not clinicians in the room, this is what we say to a family member or a friend of a family member. This is jargon and things that can change the way we show ourselves as allies in journeys such as these. So I hope that as we spend some time thinking about what jargon is, these classifications, which you'll make sure everybody has access to the slides and the scorecards, and then some simple swaps that we've started to kind of empower ourselves to make that phone call make sense for patients. I hope this was a valuable use of your time. I will pause and bring Corinne and Rachel back for questions and rousing applause.
Thank you. That was great. Sue, did I see your hand up back there? Yeah.
So, one of the things I struggle with sometimes, and maybe you have some ideas about this, is even when I'm trying to do this, the families that have children with complex medical needs tend to themselves fall into the jargon mode. I think it's part of an empowerment sense, but then sometimes you want to find a way to have some plain talk with them, and it's essentially resisted. because they've gained a great deal of control from learning this language and then sharing it back. How do you kind of break through that? Because sometimes plain talk is more necessary, and then they're holding on just as badly as I would.
Yeah, it's a great point. I think what you're describing is assessing the shot glass. So you're realizing that in this situation that somebody is requesting something, and I find myself, the example that I have more often is a medical parent and a non-medical parent in the room. And so they say a couple things in jargon to kind of get some credit, show that they could speak that way. And I often will say, "Oh, are you in medicine?" I say, what I try to do is avoid. I'm going to just try to speak plainly as if I didn't know that, unless you'd prefer otherwise. And never have I had somebody say, "Oh no, please speak jargon." They go, "Oh, thank you, because my husband X, Y, or Z." Or when my grandmother had a stroke, I didn't know any of this stuff, so I kind of hated the fact that I was a doctor and was getting spoken to in jargon that wasn't in my language. So I will use the phrase of I'm trying to, use it as a personal growth. I'm trying to really speak as plainly as possible and avoid some medical terminology, but I want to meet you where you are. So what would you prefer? And again, I'm curious if you'll hear more often than not. No, that would be great. But it's that shot glass piece. Yeah, great question.
That was great, Mike. My concern that we sometimes don't think about and you didn't mention is that we're in a room full of people with graduate degrees, PhDs, MDs, advanced degrees, and that doesn't happen in society very often. And so when we're talking to families, when we use the IRB as an example, when you write consent forms and stuff, they're in fourth grade language. And so to try to talk about complex issues to families with a fourth grade level or not much higher than that, ideally, that can be difficult. And that's where I think it's not just jargon, but even the understanding of these complex ideas that we try to discuss with them.
Yeah, I think that's a great point. Some language that can help there, sometimes is to say things like to normalize. Some of my patients like to hear every possible part of what's going on and understand it at the level of the cell. And others like me to just say kind of what to expect today. What do you prefer? And again, more often than not, it's just the facts, ma'am. It's just the beginning. And that's where I catch myself with the big picture thinking, oh, let's explain the autoantibodies in diabetes. Let's explain all this stuff, and really with that chemical that we need, insulin, that acts as a key to open up our cells. In your son, he's not making it anymore. His pancreas, that organ here, is not making it. It's our job to trick his body into thinking it doesn't have diabetes by giving him insulin from the outside. He doesn't care where it comes from. We can do. So really, as opposed to all sorts of things about islet cells that I used to try to do to make it empowering, I was just confusing. And so it's a really good point. I think I saw another question there. Yeah, Peter.
Thanks so much to each of you for doing this. Really found it interesting. One of the concerns I have is about how we got where we are and how do we move forward. And that's the system, operates to get the results it gets. And we've selected for people who can be at the top of the chain. And by asking us to speak in a different language suddenly after making it to the top is disregarding all those things we've been taught, and that's being reinforced along the way. How can we change a system so that it supports people growing up professionally to do this?
Well, better than med students to maybe answer that question. So from your perspective, what's being done in the medical school around kind of teaching you this or kind of making it so that this is not learned behavior that you have to unlearn, but kind of teaching at the beginning?
That's a good question.
I'm sorry, you go ahead.
Yeah.
Oh, it's a good question, and honestly, I can't think of a lot. I can think of a lot of clinicians that we've seen who've modeled it. The piece that you talked about that said, what other questions do you have for me? Phrases like that are really emphasized when we're being taught the basics of clinical interactions, and as far as I can tell.
Yeah, and I think you're right. Like, it's exciting to be able to kind of speak the language now that we're here and things sound familiar, and we're like, oh, this is, we're getting to that point where we can converse with other professionals who understand this. So, yeah, other than people modeling it, I think that's probably the best way that we're being taught it right now.
And there is certainly a movement that looks in medical education that communication is a skill the same way suturing is, and so being intentional around some communication skills. Sarah Jane and then Tony, and then we'll wrap up.
Oh,
sorry, Sarah.
Different Sarah. I actually have an answer in part to that question as well, because last year, and I don't know if they're continuing it this year, but for third-year medical students that were rotating their PEDS clerkship, we did an exercise as the chief residents with them where we did Jargon Be Gone, and so we had a basket and they had to choose diagnoses and try to explain it in like no jargon, and we'd offer them feedback on actually use the word febrile, what does that mean? And just as a little exercise to get them thinking about, yes, you're doing this on your PEDS rotation, but it's relevant to every rotation you'll have and it's relevant to your career. That was a little side note. I also had a question about the study, knowing that you did it weekly for 12 weeks. Was there any kind of change that you noticed that this feedback was like in terms of a QI project? Oh, that number decreased, or oh, a new crop of residents came in that hadn't been getting that feedback and the number went back up, or what that looked like?
So when we designed it, we intended to go in 3 4-week cycles, knowing that we were on the same schedule as the medical students and residents. Something we didn't anticipate was that the team actually changed every week, and so we didn't have consistency among people who were receiving our intervention. So in that sense, we didn't see the same trends that we anticipated if it had been the same people. If we redid the study, that would be something that we wanted to try and keep more consistent.
All right. Thank you very much.
Thank you, guys. Did so well.
They're still technically first year.
Still Monday.
4 days.
Yeah.
Very nice.
Thank you.
Oh, good.
You come off nervous. Came off great.
And if you ever want to go to Pete's endocrine.
Or are you the endocrinologist in the room? All right. Sorry to keep
Sorry
calling
to
out
throw
your
you out.
specialty.
No, I know you have a 16-month-old right now.
Yep.
Yeah, no, it's...
It was a really interesting, when we were looking at projects, this is one of those that you hear it and you're like, oh, jargon, but it turned out to be
Do you want to expand
fascinating.
Potentially.
And we so each year we have the longitudinal projects, and so this is something we could even hand off to a new first year and say, see if anyone's interested in trying it in a subspecialty. Like that.
Well, and then I wonder if the IRB, you would have to get the IRB involved, but if you could just go in as medical students observers, not medical students observing jargon, so that people didn't know that.
So the way we were able to get QI exemption is by not having it impact the patient side. So we weren't doing the parent survey.
No, I just think but the providers knew, right? That they were looking at jargon. So what I'm saying is, what if the providers didn't know that it was jargon they were looking
secret shopper?
We were just shadowing. And
I mean, honestly, I would appreciate something like that.
I think, because I think almost every time that we were there, people would say, like, oh, the jargon please.
Right.
Guess we better be careful, be on our best behavior today. So,
Well, if you want to do it in any division, I will volunteer mine.
Yes, awesome. Thank you.
I would know you'd have to sneak in one who's not the two of you for the But
We have a third member.
we've got a third. We didn't
all
put
of
a
our
picture
divisions
on.
are used to having students come through, and some are actually taking the rotation, and some are observing.
It could be really interesting.
And we had talked about seeing how this went and then potentially expanding to other specialties. So, and to know that there's a specialty that is interested in that.
I think everyone would.
Right. Someone once said the nice thing about peds. He's really nice. It's easier to get people on board.
That's why you should go with pediatrics, of course.
Everyone's nice, right?
Yeah. Nice project. Nice done.
Thank you. Appreciate that.
I guess one thing, I don't think you've told them about the trend that you saw.
Oh, yeah. Yeah, really.
I thought that was a three out of the 4 blocks. There was a trend, right?
Yes.
Yeah,
Yes, there was. Except the 4th block. There wasn't a trend except the 12th week. So, other than the 12th week, pretty good trend, but there was a small positive correlation. number of people who spoke during rounds and the amount of jargon words used. That more people speaking. So that was
What I've learned is
It might not be like significant, but it's like a
right.
Thanks so much.
Yeah. Thank you.
It was great.
Appreciate
I
it.
love this stuff. It's really important.
Thank you.
We do it in adolescent health. Maybe we should. Part of our job. Like they're suggested our jargon be done.
Yeah. I mean,
Yeah. Right. I think, yeah, and I think if they do it, even starting now, like it would encourage us to, instead of getting hooked on complex terms, being able to.
Learned it all. And we were rewarded for the more we use it.
Yeah.
Right. You're right on. The incentive behavior is still part of the culture.
Right.
And the press is behind me, so I want to keep on using it.
Yeah.
I'm really speaking to them, not to you as
Yeah.
the patient. Right?
Right.
You know?
Right.
Thanks so much.
Thanks.
Yeah, very cool. So Mike
right. You're to meet them where they are. Yeah.
across the country. All faculty. Spin-off. Curious about the communication course.
Yeah.
There have been a few spin-off classes.
Yeah. Working with interpreters and.
I wonder if jargon one would attract people.
Yeah.
Or if the better thing is just to try to embed a section of that into
Yeah. Well, and I do think it's one of those things like I don't think people think they need, so I think that it's actually I don't think that they would come, in a way. I'm curious actually how this is going to work at the let me just get out of Dropbox here.
Lure people with magic.
Right, exactly.
Just call it a magic class.
I was hesitant to actually, just because I've been doing this magic to open here, but I was worried about whether or not it would work for my own, like the own institution, but I guess. Yeah, thanks guys, that was fun.
Yeah.
You're a hard show to follow.
I know. Oh, and we told Dr. Marmot, but something Rachel was looking at abstract or anything. Small positive correlation.
Oh, that's interesting. Yeah, once we dig into the post. Yeah. Great work, guys.
Good deal. Well, we can, Corey should be back this weekend. I don't know when we hear back.
Should be soon. That group needs to don't need to wait. How you want to.
Okay.
I can send you guys some examples of things.
Okay.
You have been disconnected from the meeting.